survivors. He has also spent the past 5 years as an adjunct faculty at Harcum College's Occupational Therapy Assistance Program. Jim has served as a facility rehab coordinator with ProStep Rehab and director of rehabilitation services at Bryn Mawr Rehab Hospital. He was assistant chief of occupational therapy at Temple University Hospital, where he currently provided PRN occupational therapy services. Jim has presented at multiple regional and national conferences on traumatic brain injury rehab. So, with no further ado, Jim Foster.
Thank you, Laura, and thank you to the Brain Injury Alliance of New Jersey for asking me to do this presentation. Sleep is an area that affects anywhere, research shows anywhere between 60 and 70% of traumatic brain injury survivors. And I want you, if you can, to imagine there you are after surviving a traumatic brain injury, and you have a whole day's worth of rehab in front of you. And unfortunately, you only were able to accomplish about 5 to 6 hours of sleep. But you are greeted by multiple disciplines, multiple people throughout your day, between occupational therapy, who wants to have you do your morning routine at 7 a.m., and all you want to do is be able to sleep. You think you're going to be able to get some sleep after you get done your self-care, but here comes a nurse and a speech therapist with all kinds of verbal cues about taking your medications and tucking your chin and taking small bites during your breakfast. All you want to do is get done this meal and you'll have time to sleep. But no, now there's a psychologist that comes in and pressing to you to talk about your feelings since a car accident, and you're only able to use 2 or 3 word responses. I'm having difficulty being able to attend to the conversation because you're tired. You wear out really easily. And these are areas that really make it difficult to be able to progress and recover from your injury. I, as an occupational therapist, we are able to encourage and implement sleep hygiene strategies to be able to help out with improving sleep. And well, what will that do? And we're going to talk more about as one's sleep improves, one is able to attend more, be able to concentrate more, remember more, and problem solve more. And we'll talk about some case studies at the end there. So these numbers should not be surprising. We have 2.2 million traumatic brain injuries per year. Males sustain traumatic brain injuries 1.5 times as many as female. We have the incidence of traumatic brain injury is highest within that 0 to 4 age group because of the continuing developing skull and balance skills. And then, unfortunately, mortality exists most in the TBI area for individuals that are older, 75 or older, because of the other comorbidities that may occur related to a traumatic brain injury. It is harder to overcome orthopedic issues. Perhaps there are other coexisting issues such as diabetes. And then with the inability to be able to move around as much as before the accident, you are always at risk then for pneumonia. So that is why those deaths are the highest with TBI 75 and older. Every 23 seconds, one person in the United States sustains a traumatic brain injury, and there are lasting impacts on our economy related to long-term disability following a traumatic brain injury. Within REMED and comparing it to national percentages, falls right now is the highest percentage of cause for traumatic brain injuries, followed by motor vehicle accident. This number has changed recently because it used to be motor vehicle collisions, but our cars are doing a better job at protecting us during accidents. So now it is falls. But within REMED, and because of the work that we do, we are able to help serve so many individuals who are injured on job, and we have a good deal of individuals who are injured within a motor vehicle accident. So why do we sleep? It's a very important element of all of our lives, so important that we spend approximately 36% of our lives doing it. If we live to the age of 65, we will spend over 21 years of our lives sleeping. And it's difficult to be able to research what happens when we get a good night's sleep, but unfortunately, oftentimes what is occurring is that we are measuring, whether it be humans and the impact of humans or animals, when they do not get enough sleep. And what research is showing is that within an environment of rats, rats who are exposed to an environment where they cannot sleep for days and weeks will ultimately die. In terms of humans, why do we sleep? There are several theories out there. R. Foster talks about no relation. R. Foster talks about restoration of our genetic makeup, and that sequence of genes is able to be turned on while sleeping. There are specific genes that are associated for restoration. Throughout time, animals deprived of sleep will lose immune ability for their immune system to perform, and temperature regulation. And we're going to talk a little more about temperature regulation and its importance to sleep. And then there's also theories of our brain's ability to be able to consolidate memory while we are sleeping. Complex problem solving is enhanced by a good night of sleep. There is inactivity or preservation theory, and adaptive or evolutionary process. Predator avoidance is what we're talking about there. Our ability to be able to survive and animals' ability to be able to survive occurs better when they sleep. And our ability for our brain to have more plasticity. Sleep is correlated to changes in structure and organization of the brain. And then there's our esteemed colleague, B. Knowles, who talks about having peace, happiness, and healthiness is my definition of beauty. And you cannot have any of that without sleep. And B. Knowles, the B, of course, stands for Beyonce. And the attitudes of sleep over time have certainly changed. Back in Elizabethan time, the author Thomas Dekker talks about sleep is the golden chain that ties our health and bodies together. And within Julius Caesar, William Shakespeare writes, enjoy the honey-heavy dew of slumbers. Fast forward multiple generations, and Margaret Thatcher says sleep is for wimps. And Gordon Gekko says in the money movie Wall Street, money never sleeps. So the National Sleep Foundation recommends that every adult get anywhere between 7 and 9 hours of sleep per night. Older adults get a little bit less, and that's not necessarily saying they need less, but they get less in terms of the overnight sleep or extended sleep, because as we all get older, there are times when we need to be able to get up and use the bathroom. As we get older, we are experiencing more episodes of pain, whether it be arthritis or whatnot, and those issues get in the way of us being able to have a full, non-interrupted 8 hours of sleep. And as we get older, we're often then catching up on that time during the daytime and having naps. But, let it be said, though, that our sleep system and our ability to be able to, continue to get 8 hours of sleep. If we're not doing it, certainly there's going to be an impact of that over time. And we all think, well, on the weekends, I'm getting 9 or 10 hours of sleep, and I'm catching up on that sleep that I'm not getting during the week. That's not the way this works. You need to be able to, for all of us to be able to best function throughout our day, especially our injuries for the individuals that are surviving head injuries. You need that consistent 8 hours of sleep every night. So please we can't fool ourselves thinking we'll catch up on the sleep on the weekend. So what are sleep disorders? What are the different types of sleep disorders? There is insomnia. Insomnia is a sleep disorder characterized by difficulty in falling and or remaining asleep. And certainly there's a good bit of us that experience that. 58%, according to the National Sleep Foundation, 58% of adults in the United States experience a few nights a week of insomnia. There's sleep-related breathing disorders, such as sleep apnea, trouble breathing, and making sure that the lungs are taking in enough oxygen during sleep. There is central disorder of hypersomnolence, sleeping too much. That is, hypersomnolence is sleeping too much. Circadian rhythm sleep-wake disorders. Researchers believe that the sleep-wake process in our circadian biologic clock helps us regulate sleep. And if it's disturbed or damaged within a head injury, that cycle is abnormal. And we oftentimes are seeing individuals who are surviving head injuries that are sleeping a lot more during the day than they are on the overnight because of the impact of that circadian biologic clock. So that is an area that we often are tackling within this type of setting right away. We get a lot of individuals that come from acute rehab, and their sleep-wake cycles are off, and boy, we really dive into that quick to make sure that we're giving them the best chance to succeed and benefit from rehab services. So that's something that we really want to address quickly. Parasomnias, examples of those are sleepwalking, sleep eating, bruxism, which is grinding your teeth, sleep talking, bedwetting, all those different types of parasomnias and sleep disorders. And then there is sleep-related movement disorders such as restless leg system and other sleep disorders such as night terrors. So there is a whole group of sleep disorders that individuals can be experiencing. I would say, in terms of what we're seeing the most within traumatic brain injury is that circadian rhythm sleep wake disorder, and then the insomnia as well. Here is a typical sleep cycle of, I kind of refer to this as architecture of sleep, where, we all have 4 to 5 periods of rapid eye movement, and this would be, deep sleep. Periods increase in length and frequency as the night progresses, but this is when we get the deepest sleep. So we, as the night progresses, those periods become longer and longer, and we will talk later on about medications that are utilized to help out with ensuring sleep. And although they may be getting good, sleep time, extended times of sleep, there is change to this architecture when pharmacological interventions are used. The role of melatonin is an area that is important to discuss. Melatonin is a natural hormone. It's made by our body's pineal gland, and it is within the suprachiasmatic nucleus. It's turned on by that area of our brain. And it's really important because what that does is that it controls body temperature. I mentioned body temperature before. So as melatonin is released within our brain, what it does is it helps lower our body temperature. And it's inactive during the daytime. So at nighttime, as our brain starts to sense that it is becoming darker, that process goes on of releasing that melatonin and controlling our body temperature, i.e. lowering it. But if it is receiving mixed messages, for example, if we're watching a lot of television, we're sitting in front of our telephones, and we're getting that bright light, our brain is getting mixed messages. The other thing that at time occurs and gets in the way of our brain being able to start releasing that melatonin is the body temperature and the room temperature, the environment. This is one of those sleep hygiene areas that is really easy fix. We should all be sleeping in rooms that are somewhere between 65 and 67 degrees. And the reason why is that if we are in an environment where the room is cold where we're trying to get to sleep, it'll be yet another message to our brain to start that process of releasing melatonin. So again, when the sun sets, darkness occurs, melatonin is produced and released in the blood. So again, let's try to make sure that we are not sitting in an area with bright lights. I often will go around and within our rooms we have desk or bedside lights that are less brighter than the ones that are overhead. So let's make sure those overhead lights are off when it comes to 7, 8, 9 o'clock at night. And the only light in our room is softer light. And again, let's make sure we're not using our tablets or our phones. Melatonin is the only hormone that can be bought over the counter without prescription. And it does, again, help out with that light-dark signaling. Interesting area, an easy fix for all of us. So sleep disorders are 3 more times common in traumatic brain injury survived compared to general population. Nearly 60% of TBI survivors experience long-term sleep disorders. Within our pediatric world, children up to 4 years of age, and adolescents 15 to 19, we talked about are more likely to sustain traumatic brain injuries. And pediatric survivors age 6 to 12 with severe traumatic brain injuries do have a pretty significant risk of sleep disorders versus moderate traumatic brain injuries. And there are certainly factors, as we all parent, as we all work with our kids to try to make sure they are getting a good night's sleep, we all approach it differently in terms of setting limits, making sure there's a certain routine for our children as we encourage them to go to bed, and making sure that we're not reinforcing their behavior by paying too much attention to their reluctance to settle in to sleep. And because it's going to impact them developmentally if we do not encourage and make sure that people are getting, our kids are getting a good night's sleep. So within our traumatic brain injury population, what are the areas that are most impacting good sleep? And those areas generally are pain. So we have pain as a result of migraine headaches, orthopedic issues, neck pain. Unfortunately, sometimes our individuals that we serve have contractures. Those are causing pain, knees, elbows, ankles. And then heterotophic ossification, or joints that are becoming more immobile because of bony buildup. That can occur 51 to 77.9% of traumatic brain injury survivors will have heterotophic ossification. Very painful, very, very painful. And certainly we all could appreciate if we're in pain, that certainly gets in the way of sleeping. In terms of depression, anxiety, it is a substantial influence on sleep and the quality of our sleep. And that can go both ways. People who are depressed are shown to sleep more and have hypersomnolence, but then also within anxiety, people can be depressed and have anxiety and have racing thoughts. We have individuals who we are serving that their life has been impacted severely. And I'm not working anymore. I'm not with my family. I'm not with my wife. I should be coaching baseball. I should be driving. Why aren't I doing all these things? When can I re-engage in these roles again? And that those concerns are real and can impact individuals' ability to be able to focus and certainly keep people up at night, as we all worry about things. But these are huge, life-altering issues that they are struggling with. And then we talked about that altered sleep-wake cycle. Our brain's internal clock helps control when we sleep, and if injured, messages that need to be provided by our brain are altered, and they may either get less or more sleep than typically we would. Other causes of sleep disorders could be some of the medications that we are providing. At times we see individuals come in and they have difficulty being able to pay attention, especially related to therapy sessions. So some physician may decide to introduce medications such as Adderall or Ritalin, which are stimulants, to help out with attention. However, we have to make sure that are they effective, and secondly, are they impacting sleep? We talked about that racing thoughts, sleep apnea, which is again breathing interrupted during sleep. Sometimes brain's ability to control breathing after head injuries will become altered, resulting in those periods of apnea. Our oxygen level will drop, and also contributory to sleep apnea is pre-existent obesity before the injury, or a family history of sleep apnea. Urinary incontinence. Oh my gosh, this is a big one as well. So that too can get in the way of sleep. Urinary incontinence after brain injury could be caused by injuries to areas of the brain involved in motor regulation, sensory awareness, or urinary function. So these are areas that we want to make sure before somebody is laying down, like we all do. One of the last things that we should be doing is going to the bathroom. If somebody needs to be cued throughout the night to make sure that they have the ability to void in the middle of the night, if that's what needs to occur, certainly we will do that. And then sexual dysfunction as well can be a cause of sleep disorder. So again, why is it important that we take a look at sleep? What is the impact of not being able to sleep? And again, these are areas that are existent not just for traumatic brain injury survivors, but for us. So here we are, we're talking on a Monday morning. Perhaps everybody was up late watching and celebrating the Eagles win last night. And if we do not get hours of sleep, think about the impact that it has on the work that we do, our ability to be able to pay attention in the meetings that we are sitting in, our ability to be able to remember, problem solve. Are we more irritable because we do not get a good night's sleep? So throw all of that on top of traumatic brain injury, and there is a clear and positive relationship between the quality of sleep and language processing, attention, and memory. That was Weissman-Hake's in 2011. Attention, memory, and language processing. Anytime I teach and talk about cognition, I usually will draw a triangle, and the very first building block of cognition is attention. If I do not have all of your attention during this lecture, you're not going to be able to remember the information that we go over, and you're not going to be able to process it. One of those higher level cognitive skills. So there is a clear relationship with individuals who are not sleeping and those three areas. Persistent sleep disturbances independently predict poor functional and social outcomes 1 year after a mild traumatic brain injury. And performance on selected measures of cognitive function significantly improved with improved sleep disturbance after TBI. So this is why. This is as individuals come into our program and we do identify a sleep disorder, I am dialoguing with our OTs and our psychologists, our neuropsychologists. Let's get that cognitive baseline. What is going on in the mini-mental status exam, in the Cognostat, in the RBANs? We're going to talk about these standardized tests that we utilize, and then be able to help out with sleep and see the impact and the improvement in cognition. Our prefrontal and temporal lobe in sleep-deprived brains will increase activity during performance of simple verbal and language processing skills. So again, the sleepier the brain is, the greater that our prefrontal cortex must work. And then, of course, you can appreciate attention and reaction time is impaired in sleep-deprived subjects. So think about yourself in a long car ride where you are not able to get up and stretch and move around, and our attention and reaction time may be different if we are sleep-deprived. So again, the impacts are attention, memory, visual processing, and cognitive fatigue. Cognitive fatigue is an area that's different necessarily than sleep. We already know that individuals after traumatic brain injury their brains are working so much harder to be able to pay attention, to remember things. And because of that, they do experience cognitive fatigue much quicker than those individuals who are not have not experienced a traumatic brain injury. And that is only going to happen quicker for individuals who are not getting a good night's sleep. Laura, I see a question here. Should I be okay to address these, or should I wait till the end?
That would be up to you, whichever you prefer.
I don't see the whole. I'm trying to see what it says here.
Okay, let me see. Do people with brain injury require more sleep than the general public?
That's a great question, and I would say no. I think if individuals who experience traumatic brain injuries, if they get their 8 to 9 hours a night, that is a great start for them. But as I just talked about in that previous screen, survivors of traumatic brain injury do experience cognitive fatigue. So what do we do about that? There are times when we make sure we schedule breaks for individuals throughout their day to be able to not necessarily get more sleep, but to be able to be in a quieter environment where they can just sit and recharge their cognitive batteries in a non-stimulating environment. Again, that's not necessarily getting more sleep. It's just taking a rest break to be able to recharge their cognitive batteries. But no, I would not say that somebody who has a traumatic brain injury necessarily needs more sleep. That's a great question, though. But the other impacts of sleep disorders are making sure that what could happen is you could have a lower seizure threshold. You also can be more delusional, have hallucinations. If you're not sleeping, certainly you are at increased risk for depression. And we all can appreciate, again, if we're not getting a good night's sleep, we are more irritable. So what are the different types of medications that are utilized within the TBI survivors to help with sleep? I often say within our world, we don't necessarily have our own medications that we utilize within this brain injury world, but we take medications from other diagnoses and other worlds to help address certain symptoms. So serotonin antagonists and reuptake inhibitors will certainly alter levels of serotonin in the brain that is generally used to help out with depression. And it also has a side effect to help with sleep. And trazodone is one of those examples of an SARI. Atypical or secondary generation antipsychotics are used within the TBI world. And I will often, as we are introducing these medications, I often preface it by saying, I know you're going to Google this, and it's going to say that it's an antipsychotic, and I'm not psychotic. My loved one's not psychotic. Agreed. But what we're doing is we're, helping out with the mood swings, helping out with disorder thinking, and one of the main side effects of these secondary generation medications is that it will cause drowsiness and fatigue, which when we give it to individuals on the overnight, that does help them sleep better. So examples of those, Seroquel, Risperdal, and Geodon. And then there is non-benzos that are specifically made to help out with insomnia. And these medications are, originally considered to be less addictive than benzos, but they too can be habit-forming. Examples of those are Ambien, Lunesta, Sonata. Lunesta we've been using a lot recently and have been getting some good outcomes from that medication. So before we will introduce these medications, at times what we are is we're having conversations with our physicians and talking about how successful we anticipate sleep hygiene strategies to be, and do we need to introduce these medications, or should we allow the opportunity for sleep hygiene strategies to be introduced and take effect? So these are conversations we're having with our physicians all the time. So these are what we do is certainly we're providing education. And it's terrific to be able to sit down with somebody if they have the ability to be able to, the insights into it, to be able to educate on the importance of sleep hygiene. The use of schedules, the use of reminders. We have the American Cognitive Rehab Manual. We often use orientation sheets. And what we'll do is we'll incorporate sleep hygiene techniques or reminders within their orientation schedule on a daily, hourly basis. So it's great when we have individuals who can appreciate that they are not sleeping well and be able to take in the information and want to be able to use it. So many times people will come in and, again, they're only sleeping 6 or 7 hours a day, and they so want to be able to go to sleep. We just had a woman who we discharged, and she had a great insight into she was not sleeping well, and help me. Please help me get a better night's sleep so I can focus more throughout the day. And it was great to be able to do education with her and be able to help her with these sleep hygiene techniques. We talked about environmental modifications, so a darker room, a cooler room, and again, making sure that our body's temperatures have the ability to be able to drop. And then, positional issues as well. Encouraging individuals to stay out of bed unless you are sleeping. The brain has fantastic association capacity to be able to associate one thing with the other. And what we want individuals or brains to associate is bed with sleep. So throughout the day, you should not be in bed. We set up a special chair for this particular woman I was just referencing. She enjoyed reading, but she, when she came in, she was reading in bed. And so we got a nice comfortable chair for her to be able to sit in her room and do her reading and try to make sure that her brain would start to reassociate sleep with the bed versus hanging out during her downtime. Dietary considerations also as well, making sure that we're not having caffeine after 2 o'clock in the afternoon. There are soft foods that one should have at nighttime versus hard crunchy pretzels or crackers or cookies are stimulating to our brain versus softer foods such as oatmeal and yogurt are more soothing foods. The other considerations are, use of relaxation techniques, breathing, and meditation are areas that we will educate our clients to. In addition to, we use a white noise machine in just about all of our rooms to help out with drowning out any of the noise within the program. Again, we talked about our pharmacological interventions and making sure that those are scheduled at very precise times. We often will have, conversations about, do we give them at, 7:30, 8 o'clock, 8:30, 9 o'clock? What is the right time for that person to be able to get their medications? Because there's several issues. At times, people are getting too tired. And one of the behaviors that we often are managing is individuals who are refusing their medications. However, they need their, Seroquel, Lunesta. They need that to ensure that good night of sleep. So we often are, having, important dialogues with our nurses and our brain injury specialists about, what do the nights look like? What time is best for this particular person to receive their medications to, so that the best impact on sleep is felt. How do we know that somebody is sleeping? We stopped putting clowns underneath the beds, so we don't use that method anymore. However, we have staff that are collecting the data, and we certainly don't want staff kind of opening the doors and popping their head in and saying, "Are you asleep, Mr. Jones?" No. So we need to be really careful about how we collect data on sleep. At times, individuals may have insight and capabilities to collect their own sleep data. What time did you go to bed? What did you wake up? What time? Did you wake up to go to the bathroom? What did you do during that time? What did you do to help yourself get back to sleep? What time did you wake up in the morning for your AM routine? It's great when individuals who are so invested and involved in the process can sort of collect that data on their own. The other advancement that has been great is the use of electronic monitors. Certainly, the use of these tools initially was to help out. We're all keeping track of our, making sure we're getting over 10,000 steps a day, but they also are great at monitoring sleep. And how do they monitor sleep? What they are doing is measuring a decrease or a lack of movement and a decrease in heart rate. So most of them do not factor in the time it takes for you to fall asleep. So whether it takes you 20 minutes to fall asleep or 40 minutes, that time is generally not included within your sleep cycle. And once you stop moving for a certain length of time and your heart rate has decreased, the device assumes that you are asleep. There is really good validity. I found the most recent was Zambati et al. In 2015 was comparing the data that these monitors, risk monitors, and comparing it to true sleep studies, and is really good validity with these devices. We generally will use the Garmin wrist monitor device, and it is really good data that I'll share with you in terms of what we get from this information. And it's great to be able to, once we sync this, every week or so, to be able to sit down with somebody and say, okay, here's what this is showing. Do you endorse it? Do you understand it? Let's talk about this particular night that you did not get a good night's sleep. Tell me about your environment that night. Tell me about your hygiene. Tell me about, did you eat something funny? Or is there something on your mind? Were you in pain, in particular pain that night? What were the obstacles to you getting a good night's sleep on this particular night? And so it's a really great device that makes tracking sleep more objective. So then we look at the cognitive measurements. I talked about, this is the why. Why is it that we want to help individuals sleep? Because we want individuals to help be able to pay attention more, remember more, problem solve more. So how do we do that? We do a good bit of tracking on macro trackers, hour to hour, half hour to half hour, 15 minutes to 15 minutes. How are they doing with being able to, are they sleeping or are they awake? What are they doing throughout their day? Are they, we will, for some individuals, track irritability through different behaviors, perhaps yelling, screaming, verbal outbursts, all those different types of things. We will qualify, first of all, what behaviors an individual is demonstrating, and then make sure that we are tracking it. The mini mental status exam is a very simple cognitive test from 0 to 30. Looks at orientation, registration, attention, calculation, recall, and language. A very common test that we also use is the Mayo Portland Adaptability Index, the MPAI. That is a scale of 1 through 4, and it looks at areas such as endurance and different types of behaviors and attention as well. A very detailed test assessment that our neuropsychologists use is the R-bands. It's a repeatable battery assessment on neuropsychological status. That takes a look at immediate memory, visual spatial skills, attention, and delayed memory. And again, the important piece of this one is the R, the repeatable. That once we do identify somebody who has a sleep disorder, we'll get an initial R-bands and then be able to repeat that battery after we believe that the sleep has improved. One of the areas of attention within the R-bands is the trail making test. That looks at visual attention, looks at working memory. And the trail making test looks like this. There's an A and a B. This is the A. So you can appreciate the attention that one needs to be able to exhibit, to go from the 1 to 2 to 3 to 4 and draw those lines. The average time, standardized time, is about 29 seconds. If it takes you longer than 78 seconds, then that is, certainly your attention is impaired. And then the B is distracted attention, being able to look at, go from 1A, 2, D, 3, C, and so on and so forth. It takes a little more time. The average time it takes for this is 75 seconds, and if it's impaired, attention is impaired if it's longer than 273 seconds. So these are some good standardized tests for us to be able to repeat and take a look at how somebody is doing with their attention. And it's, again, it's something strictly that's impacted by sleep. So if what we'd like to do then is, let me transition over to a couple case studies. AO is a 34-year-old woman who sustained a traumatic brain injury in February 2010 as a result of a motor vehicle accident. Her residual deficits included some left side hemiparesis. That also included some contractures. So she was in tone, and some pain issues were impacting her sleep. Expressive and receptive aphasia, cognitive deficits, plus she had some mood and then the sleep disorder. She admitted to our ReMed short-term rehab program directly from a nursing home, and the plan was for her to be able to go home with her family. And this poor sleep issue was very important for the family to be able to help fix, and would make things a lot easier for when she did go home with them. Her initial presentation consisted of restlessness. She would kind of propel herself up and down the hallways here in her wheelchair. She would have verbal agitation, verbal outbursts. If people got in her way, or if she got frustrated. Her sleep was not good at all. Poor attention during her rehab sessions. And what the team started to do is, there were some medication changes, such as she was on Ritalin, initially 80 milligrams daily. That was reduced. And to help out with mood and sleep, 100 milligram of Seroquel was her end dose that she was on. She was somebody who liked to have a nighttime snack. We started to have warm oatmeal as a PM snack. We had actually time-scheduled naps, 1 hour in the afternoon. We used a white noise machine, and we made sure that, from a toileting standpoint, that she was cued all throughout the day. So in January, she was not oriented to place time. She attended to tasks only 5 to 10 minutes, and she was unable to retain 4 words after 10 minutes. And after sleep was improved, less restless, she was able to attend to tasks 20 to 30 minutes. She was using a verbal augmentative communication device, which improved her accuracy from 50% to 80%, and there were less episodes of verbal outbursts. Another case study would be DR. She was a 46-year-old woman who was injured in 11 of 2015. She had a pretty significant frontal temporal subdural hematoma, seizure activity, hemiplegia, and pain issues. And she was admitted to ReMed in June of 2015. She was only sleeping an average of 6.5 hours of total sleep daily, and she had impaired memory, attention, presence of daily fatigue, and she was somebody who became very easily agitated. What happened with her is that we also introduced Seroquel. We did a ton of sleep hygiene education with her, and we actually had reminders on the orientation sheet for her sleep hygiene reminders. And it was also posted in her room, in the steps that she needed to take. And this is something that it sort of takes a look like this. We give these steps for individuals. Stay out of your bed during the day. Between 7 and 8 o'clock, this is a woman who liked chamomile tea. Spend some time in your room with only a bedside light turned on. Make sure that the overhead light was off. Start your PM routine. Get in your pajamas. Brush your teeth. Go to the bathroom. Ask for your medications, including the Seroquel that helped out with sleep, and this is a woman who had some pain issues, so gabapentin was used. 8 o'clock, this is instead of getting into bed, sit in your chair and read your book. Turn your TV off around 9 o'clock, turn on your white noise machine, and when you start to feel tired, this is the important piece. Don't get into bed until you start to feel tired. Then turn off your lights and get into bed. And make sure your bed is flat, and there you go, you fall asleep. If you do wake up and you cannot fall back asleep, turn your bedside light back on again and get out of bed. Don't be tossing and turning in your bed. Again, we're trying to connect that association with our brain of bed and sleep. So get out of bed and sit in your chair and read again. Only return when you are ready to fall back asleep again. If you need help with staff, the other thing what we are trying to do is encourage her. This is a woman who would kind of move around the program a lot when she first came in. So different rooms, different temperatures, different light settings, different noises. She was actually somebody who would kind of get out of bed and then move around the program, and at times lay back down on our physical therapy exercise mat. And again, trying to avoid those exposures to different sounds, different lights, different temperatures. We asked her to try to use the call bell if she needed staff to help out with her, and she was somebody who started to follow that. This is the data that is provided by the Garmin. You can see the totals, 8.35 to 9, and the dark blue. This is the great thing about this is that it breaks it into deep sleep and light sleep. And those pink times, those pink colors are when somebody wakes up. And this is somebody who we were able to improve the total number of sleep and some significant, she had some really good deep sleep. That was a pretty big jump in about an hour or so a night of deep sleep, which was really great improvement for her. So what? So again, why do we want to make sure that their sleep is improved? So this was the R bands from her initial one to September, almost 2 months later, and she, as you can see, she improved in memory. She improved significantly in her ability to be able to express herself. Big jump in attention, and her total score jumped from 60 to 70 in this R bands, which was great. This was great progress for her cognitively. Me as an occupational therapist, I take it another step forward and say, all right, so there was an improvement in her mini mental status exam, big significant in trails, but most important to me is function as an occupational therapist. She wanted to go back to driving. And as we all know, there are some significant cognitive skills that are needed to drive every day. Being able to attend, obviously, to different stimuli. Being able to remember the rules of the road and what the signs are. So I was most proud of this particular number with DR in that she, when we first had her take the Pennsylvania driver's permit test, she only had a 72, which is not passing. And several months later, her sleep is better, and she was able to pass it with flying colors. So that was a really nice outcome and a really nice improvement noted with her improvement in sleep. There are references, and I see there is another question here, Joanne. I'm sorry, Laura, is there another question here?
Yes, let me read that to you. Is there any data about the validity of non-wearable sleep tracking devices such as MFit?
I'm not aware of that one. Again, we tested off a couple of them, the Fitbit and the and the Garmin, and I showed you the data for the Garmin, and that's the one that we've been using. I know Dr. Michael Marino is our medical director, and he is in the process of Moss Rehab and several other facilities. They are continuing to look at multiple devices to be able to track sleep and their effectiveness. So I can certainly get your contact information and try to get the two of you together to sort of further address that. But right now we're primarily using the Garmin, namely because we really do like the data that we're getting from it.
And I have one other question, Jim, in regards to if someone takes medication to fall asleep versus not taking medication and sleeping, is it the same health benefits for the body?
That's a great question. So certainly every medication has side effects, including Seroquel, Lunesta. So the goal would be, we often get that question, are they going to be on this medication for the rest of their life? And my generally, and again, I'm not a physician, I'm trying to stay within my lane, but what we've experienced is that at times some of this medication, the further away they get from their injury, they're able to wean themselves off of these medications and be able to use strictly the sleep hygiene methods. You also hope that some of those factors that are impacting sleep, such as pain, such as anxiety, such as depression, those restless thoughts, those things can be managed so that they are not as much of an impact during the acute stage of their injury versus later on, and then that's another way to make sure that the sleep is getting better as well. I hope that answered that question.
Yes, thank you.
Any other questions?
Let me take a look. I don't see any at this time. So if anyone has a question you'd like to send it in right now, you can do so. Or otherwise, if you think of a question after we've finished, then you can write it into myself, and I'll make sure that Jim gets the question and can get back to you. Okay? So are you completed, Jim?
I am.
All right, so then at this time I'd like to thank you so much for volunteering your time to present on such an important topic. I know that I'll be using the strategies some of the strategies that you presented today, and also my son. Again, if we did not address your questions or you have one after the event, you can email me. My name is Laura Jacobs at the Brain Injury Alliance, and that email address is ljacobs, LJACOBS at BIANJ.org.